Dr. Harlan, thank you.
Thank you very much. Really sincerely appreciate the invitation. It's an honor, a very special privilege to be with you this morning. I'm going to share my screen. And once it's up, I'll ask you if you, can you see my screen?
Yes.
Okay, perfect. So today we'll talk about sickle cell disease and COVID and COVID vaccines. So we'll make some general remarks with respect to COVID-19 itself, and then we'll, for the second half of the presentation, we'll get into vaccines. Let me start by stating what we already know, and that is we know that there are health equity issues that have contributed to an increased risk of COVID-19 among various groups. We know that as a result of several of these health equity considerations, members of the racialized communities, including the Black population of North America and Europe, have been disproportionately affected by COVID. Issues relating to discrimination, access to health care, the types of work that people do as being on the front line of the workforce and increased exposure to COVID, the income categories and wealth gaps, housing, are all factors that have contributed to an increased risk of COVID. And indeed, just to set the stage, if you look at what has happened in the United States, for example, these are data that indicate that when compared with Latino Americans and white Americans, Blacks are much more likely to die from COVID. And indeed, if you look at those three groups, whites, Blacks, and Latino, infection rates among Blacks and Latinos are significantly higher than among whites in the United States. Interestingly, Blacks have the highest rate of hospitalizations. So in addition to the high rates of hospitalizations, we know that Blacks are having bad outcomes, including mortality. There are many reasons why various groups might be exposed to COVID and therefore have a chance of having a poor outcome. If you look at the ability of individuals to work from home, and I alluded to this earlier in terms of the types of occupations that people have, in the United States, whites are much more likely, much more able to work from home compared with Blacks and Latinos. And in the Canadian context, as far as Blacks versus whites, it's that same situation where certain individuals in racialized communities, such as Blacks, are much more likely to be on the front line of the workforce, less likely to be able to have jobs that allow them to work from home. I want to show you a couple of slides that relate to the disproportionate representation of COVID among different groups in the Canadian context, at least in Toronto area. And this slide showed the reported COVID-19 infections by income categories, where the extreme right, you can see individuals making $150,000 or more, and they account in blue for 21% of the population of Toronto, but only 6% of COVID cases. At the other extreme are individuals making less than $30,000 a year. And those individuals account for 14% of the population, but 27% of COVID cases. In the middle are individuals who make between $50,000 and $100,000 per year, approximately. And those individuals, you can see there's a closer connection between their share of the population and their share of COVID, so to speak. So for the 50,000 to 69,000, 14 and 16%, 70,000 to 99,000, 17, 15%. So these are closer, and in an ideal world, that's where things ought to be, that your share of the population is your share of COVID. But in situations where on my graph here, where the gray bars exceed the blue bars, that's not a good situation. You're getting more COVID than your share of the population, so to speak. Now, if you look at the next slide, and this shows the reported COVID infection by ethno-racial groups. And this shows at the extreme right that whites occupy 48% of the population and get 17% of COVID cases. This is in the Toronto area. At the extreme end, you can see in the left of my screen, Blacks occupying just about 9% of the population in Toronto. Let's call that 10%. And they get twice as much COVID, 21%. So they're getting more COVID than the white population, even though the white population occupies 48% of the population, nearly half of the population. And in fact, again, where the gray bars exceed the yellow bars is where the population is disproportionately affected. And in that regard, the only two groups where the mustard bar exceeds the gray bar would be the white population and the East Asian population. So just about most, if not all of the other populations are disproportionately affected. Now, and I could show you additional data for areas like Peel in Ontario. It's a similar trend. Now, with respect to vaccines, one of the first questions was the extent to which different groups around the world would accept a vaccine, a COVID-19 vaccine, if one became available and it was shown to be safe and effective. And this survey done, published in Nature, one of the most reputable medical publications, showed that Canada was in the middle of the pack, so to speak, at about a 70% acceptance rate. So it's still at about 30% of the population not willing to accept if a vaccine became available. Now, we know that this is not uniform across each group in our society. There are some folks who would be greater or lower with respect to their acceptance. That said, a 70% acceptance, 30% non-acceptance is still not ideal because of what one needs to do is to have enough of the population vaccinated to achieve what we refer to as herd immunity. And to achieve herd immunity, we think we need somewhere between 65 and 70% of the population vaccinated at the very minimum, ideally 80% or even more, but at the very minimum, 65 to 70%. So Canada is just barely getting there, assuming vaccine gets out to everyone eligible to achieve this, cutoff of 70%. So let's get a little bit more granular with respect to vaccines themselves. And in this regard, my goal is not to make you out to become a molecular biologist with respect to the virus, but there's one thing I wanted to point about the virus because this has been in the news, and this is the spike protein. This is called the S protein on the surface of the virus. And this spike protein depicted here in this red thing, this red cartoon, attaches to a receptor on the surface of cells in our respiratory tract. And through this connection, a series of interactions follow that allow the virus to enter the human cell. So therefore, if one wants to prevent the virus from infecting us, prevent the virus from entering human cells, then one of the things that we can do is try to knock out this spike protein, try to prevent it from coupling to the human cell. And so the vaccines that are developed are targeted at this spike protein to disable it, to knock it out so that the virus cannot bind to cells to infect us. And I know that's a gross simplification, but roughly that's what we're looking at. And this has led to the development of a number of different vaccines. And there are 4 categories of vaccines. One where one takes the virus and either kill it and give it as a killed shot, for example. Work is being done on this vaccine. Or one takes the virus and weakens it and then injects it. The other extreme would be proteins that are little segments of the virus or particles that with the help of really fascinating technology, including plant research, to be able to develop virus-like particles that are really as a result of the plants themselves being injected with the spike protein, and the plants basically producing particles that look like the spike protein. And I'll talk some more about that because it's really interesting. And then we also have where one uses other types of viruses to allow for the spike protein to be taken into cells, or the nucleic acid vaccines, such as the mRNA vaccines, the Pfizer and Mrna, and we'll get into some more detail about those. So let's look then in this simplified cartoon of what these various vaccines are all about. So in the middle is the SARS-CoV-2 virus that causes COVID. And this squiggly purple thing would be the nucleic acid. On the spiky thing on the surface would be the spike protein. And in the mRNA vaccine, one focuses on the mRNA. So essentially, that's the mRNA template is developed, and I'll explain in the next slide what exactly that does. In the case of the whole virus vaccines, it could either be a weakened or killed virus, as I alluded to. We can have other types of processes that allow for the vaccines to be appropriately targeted. But for the purposes of the presentation today, we're going to focus primarily on the mRNA vaccines, because those are the ones that have been approved for use in Canada. The virus-like particles are really fascinating. There's a company called Medicargo out of Quebec, where essentially what they do is use plant technology to produce virus-like particles. And essentially what happens is that the plants are injected with the spike protein to create and respond to its presence by producing other types of particles that look like the spike protein. And when that's injected into a human, our immune system sees it and it looks like a virus. And so if it looks like the virus, it responds, the immune system responds as if it's a virus and develops the immune response. And that's fascinating, but there's research that is ongoing in this area. It's just not ready yet, and it's obviously not approved yet. So what we have right now then are the mRNA vaccines. But there are many others. Altogether, there are over 200 vaccines that are in various stages of development. 48 of them are in clinical trials. The top four, the Pfizer and Moderna mRNA vaccines, and then we have a couple others, the Janssen or Johnson & Johnson vaccine, and then the AstraZeneca Oxford vaccine. So these are the top four contenders. So how do the mRNA vaccines work? So I made reference to that spike protein earlier, and essentially what one does is that one takes the code, the genetic code for the spike protein and inject it, and I'll tell you how that's done, into your arm, into a muscle. The body responds to that by producing proteins in response to the genetic code. And those proteins that are produced mirror the genetic code. And the genetic code is for the spike protein. So what is produced is a spike protein. The human immune system sees a spike protein and thinks it's a whole virus and responds essentially to the spike protein, making antibodies that help to knock out the spike protein and knock out antibodies. And in a gross simplification, that's basically how they work. A little bit more detail then, the spike protein is coded for by the mRNA. But if one were to just inject mRNA into your arm, it would break down in seconds. mRNA or RNA is very unstable, and that would be broken down very quickly. So what has happened is that the mRNA then is coated, it is wrapped in a lipid, fat. And the way to think of it is almost like a raisin. Imagine that the mRNA is raisin and the coating is chocolate. And so it's like a chocolate covered raisin that is obviously many, many scales smaller, times smaller than a real, chocolate covered raisin. But that's the concept, that lipid coating adds stability to the mRNA, allows it to be packaged into a vaccine vial. There's other chemicals that are added to that, which I'll talk about later. Those allow stability of the mRNA vaccine. That is then injected into your arm, then enters the cell. The cell sees the genetic code for the spike protein and responds to it by producing spike protein. Your body then develops antibodies to that spike protein. So that's pretty more or less how these vaccines work. Now, to break it down even further, in the normal situation of how our bodies work, DNA is responsible for creation of the sequence of events called transcription that result in mRNA being produced. When mRNA is produced, called messenger RNA, messenger RNA essentially sends the signals to our immune system, our cellular machinery, to make proteins that mirror the message that the mRNA is sending. So in that regard, the mRNA is sending a message to create spike protein, and so the spike protein is produced. Now, it's therefore not the normal pathway where one has mRNA, it goes to DNA. mRNA doesn't go to DNA except for when there's a process called reverse transcription. And that reverse transcription and the sequence of complex mechanisms to create reverse transcription does not occur in our cells. And so one of the questions that often comes up is, could the mRNA vaccines modify human DNA? And the answer to that is no. And the reason why that is no is that the for the DNA to be modified, DNA would have to be incorporated into DNA. And the mRNA vaccines are going in that direction. They're going away from DNA. They're not going in the direction of a reverse transcription to create DNA that would be incorporated into DNA. So furthermore, the mRNA that is injected into muscle, it breaks down very, very, very quickly. It enters a part of the cell that is not where the DNA is. You know, it's a different compartment of the cell. It breaks down very quickly, and our cells do not have the complex set of enzymes to create DNA from the mRNA template. But our cells do have the enzymes to create the proteins from the mRNA. So bottom line is that the mRNA vaccines will not alter our DNA. I wanted to, over the next few slides, share with you some of what we know about the side effects of the two main vaccines that have been out there, the Pfizer vaccine and the Mrna vaccine, and I will simplify this slide. First, the main point is that when the studies were done, these are the efficacy studies where active vaccine was given to thousands and thousands of individuals compared with placebo. So some folks got active vaccines, others got placebo. And what was shown is that systemic symptoms such as fever, headache, muscle ache were more likely to occur after the second dose. So that's the main take-home point from this slide. The second point is that when they looked at individuals who are older, equal to or greater than 71 years of age, systemic symptoms tended to be lower among the older population. It's certainly something to be mindful of and to watch very carefully, just to ensure that that in no way is related to differences in how well the vaccines are working. But so far, it does not appear to be the case, but obviously it needs to be looked at very carefully. So again, systemic symptoms tended to be lower among older individuals. So more side effects after the second dose and less side effects among the older population. Overall, the vaccines, though, are felt to be very safe. They're among the safest of vaccines that have been manufactured. I know many people have asked questions about how comes these are produced so quickly. We'll talk about that in the question and answer, because I'm sure that's, you know, if you don't ask that, I will ask that and answer that. But overall, these are incredibly safe products that we're really very fortunate to have in the fight against COVID. I realize that in this fight against COVID, there are many historical challenges that we face. One of these historical challenges relates to mistrust of the healthcare system over generations. One of the most egregious of these is the Tuskegee Experiment that started in the 1930s and continued to the very early 1970s, over 40 years, where African American men were followed in a natural history study, and they were basically told that they had bad blood, and when penicillin became available, their syphilis was not treated with penicillin. So that's you know, it's absolutely terrible. And we accept that, we know that. But we also know that for us to move forward, we're just going to have to not forget the past, but to learn from the past. And in this photograph that I'm showing you here, one of the people who participated in the Tuskegee experiment was indeed a Black woman. The nurse coordinator was a Black woman. Whether or not she knew the details of exactly what was going on is up for some debate. But bottom line is that there are lots of egregious issues and errors with this, and has led to mistrust. So I get it. The healthcare system gets it. We all get it, as far as being aware of the historical context that we're working with, and wanting to define how best to move forward while not ignoring the past, but learning from the past. So with that, I'm going to stop so that we can spend as much time as we need to answer questions.
Thank you very much, Dr. Hopton. I think you have really brought clarity to many of us when it comes to COVID-19 vaccination. And now we're going to look at the chat box and the Q&A. And like we said, if anyone has any questions, please type your questions, or you can also raise your hand. I see Eunice Ramsey raised hand. Perhaps we should allow Eunice to ask her question first before we go into the Q&A box. I will unmute you, Eunice. Eunice?
Can you hear me?
Now we can hear you.
Okay, thank you. Thanks for taking my question. Regarding to the reverse transcription, what happens to the patient, the sickle cell patients, when they take it, and how much study have been done on these patients, especially the children, the younger ones, I would say from 0 to 10. What happens to them when they take in this vaccine, and what if one's immunity cannot tolerate the mRNA vaccine? What happens to them?
Okay, so just to clarify then, the process of reverse transcription with the mRNA vaccine does not occur. So that's the point I was making, does not occur. It goes from RNA, mRNA to the creation of spike protein. So that's an important point. As far as the Moderna and Pfizer vaccine, there's somewhere about 10% of the people who were studied were Black. And so we take the Pfizer, for example, they had about over 30,000 participants, and just over 3,000 were Black. So about 10%. Ideally, one wants more, but that's what we have. We don't have enough data for children as yet. So Pfizer enrolled down to 16 years of age, Moderna 18 years of age. But we know that there are studies now that are being set up that will include children. We don't have enough data on the numbers of patients with sickle cell disease who were included in the trials yet. I would not think that we would have sufficient numbers to draw any definitive conclusions. That said, we don't have any biologic basis to think that a patient with sickle cell disease would have any less ability to respond to these types of vaccines than somebody who didn't have sickle cell disease. It's a different scenario with respect to the use of certain types of vaccines in some children with sickle cell disease, where they might not have a good enough a response compared with other types of vaccines. We don't believe that will be the case with the mRNA vaccines.
So you would suggest, in your opinion, then, that the non-adaptive receptors in sickle cell children from, 0 to, say, 10 again, you don't have the data. So therefore, this is just a trial and error then, if that 10% that you mentioned, if it affects the child or the patient, what would be the course of treatment, and what if that person does not survive because of this vaccine that is given to a body that didn't have the disease, but you introduce a dead virus into a live body, and the correlation and how all of that. So it's basically, then it's a trial and error, in my opinion, how I feel. Not that I'm not receptive to vaccines, but as a healthcare provider, like, I would feel horrible knowing that I've given a vaccine to someone that potentially could harm them because their body could not, their body could not adapt to these proteins that is being introduced to them.
So that's you've used some terms that are interesting in another context, but in this specific context, what is really important is that is what I said earlier, is that based on what we know about how the immune system in a child works, we would not expect the mRNA vaccines to result in an inability to respond or major concerns. That said, the research is being done. And that's why the current licensure for the vaccines, for children, it's down to 16. And for the Pfizer vaccine and for the Mrna vaccine is down to 18. Because the way that vaccine approval works is that agencies like the FDA and Health Canada only approve what was studied. And what was studied is down to 16 and down to 18. And so they're not approved for children yet. It's not that we don't think that they'll work in children, we just don't have the data yet. And so those studies are being done for children at the moment.
Thank you very much. So my last thing is that then what I'm gathering is that children should not be vaccinated, from 0 to under 16 then, because there's no data to back this up at this time. Anyhow, thank you very much.
Welcome.
Thank you very much, Eunice. Thank you.
We shall move to our next question. Thank you, Dr. Allen, for the talk. The next question is, there are several videos being shared online. These videos show doctors in different countries disputing the validity of the COVID-19 vaccine and encouraging viewers not to take the vaccine. Some of them say taking the vaccine can change one's DNA. Others say the vaccines were developed too quickly and can't be trusted. What's your take on this?
Well, I addressed the issue of changing the DNA. It doesn't happen, and I gave examples of why it didn't. The issue around the vaccines being developed so quickly is only partly true, and let me explain to you what has happened there. The process of developing the mRNA vaccines started about 20 years ago or more for the treatment of cancers. And the idea was to try to take a piece of a cancer cell, sequence it, identify the genetic code that relates to certain proteins connected with the tumor itself, and then get the immune system to respond to messages that the mRNA send to create proteins that the immune system could attack and therefore attack the cancer. And so that work has been going on for decades. So when COVID came along, that technology had reached the point where one could ask the question, well, maybe if we don't focus on a cancer cell, and maybe if we focus on a virus, and they've been looking at the original 2003, 2004 SARS virus, and they were looking at the MERS, Middle East Respiratory Syndrome virus as well. So that the work actually had been started, and the development of the mRNA vaccines against COVID actually represents a luck scenario and a good news scenario. In other words, if COVID, as I told a group that I spoke to early this morning, I spoke to another group this morning at 7, and on the diaspora online with Dervin Malcolm. As I told Dervin, if COVID had come in 2003, and we would be quote unquote toasted, we would not be ready. We're just fortunate that COVID came in 2020. In other words, the vaccine technology would not have reached where it has reached now for us to develop this vaccine. So we're really very fortunate. And so, yeah, it might appear that it's quick, but it's not really quick. The mRNA technology part of it has been going on for a long time. It is. Once you get the studies going, it is possible to get the mRNA vaccine out sooner than the other vaccines, but there has been work that had been started decades before this.
Thank you. Thank you so much. We go to the Q&A box now. I guess the first question is, can our children below 16 years get vaccinated?
So at the moment, that's a great question. Made some comments about that earlier. Now, at the moment, the FDA and Health Canada only approve vaccines based on what was studied, at least initially. And so the Pfizer vaccine went down to age 16, and the Mrna vaccine went down to age 18. So that's what's been approved. And we don't like to use vaccines in scenarios where they haven't been studied. And that's why they haven't been approved for children as yet. That said, there are some very special situations where we and others are having a closer look to see whether or not for a particular high-risk population of children, older children, whether or not the benefits might outweigh risks. And so that's something that is being looked at very closely at the moment.
Thank you, Dr. Hoptin. The next question is very similar. So this individual is asking that since neither vaccine is approved for children, what do we do for our sickle cell kids, the children? What do we do?
So that's a really great question. When we think of protecting children, with vaccines, we think of two strategies. Strategy number one is to vaccinate those around them or those who care for them. It's a concept that we use in infectious disease and public health called the cocoon effect or ring vaccination. And so healthcare workers who care for vulnerable children, whether it's children with cancer or weakened immune systems, children with sickle cell disease, others, that those individuals are vaccinated family members, caregivers at home, that when the time comes that they be vaccinated as well. So you protect those around them. And the second strategy, of course, is to vaccinate the individuals as soon as we have the data that support their the vaccine use in their population. There are, as I alluded to, efforts being made right now to determine if there are some groups of children in extremely high-risk settings that might require, vaccination, might warrant vaccination. And that's being looked at. For example, if you live, an example, if you live on Baffin Island, remote areas of the country, Northern Ontario, where it's difficult to get to an intensive care if you get sick, should you just go ahead and vaccinate children down to a certain age? And that is being looked at.
Thank you.
I will move to the next question. You may have already alluded to this. How was the vaccine created so quickly?
Yes, so again, that's a result of work that we were fortunate to have had going on for decades. And as I said, if COVID had happened in 2003, 2004, we wouldn't be where we are today. So we're really very fortunate. So the development of these vaccines, although it might appear to be quickly done, yes, there are some parts that were accelerated, but without cutting corners. It's just that there was a lot of work that had been done before to allow for us to be where we are today.
Excellent. Thank you very much. The next question is the off-label use of ivermectin effective for COVID-19, or is this another hoax?
We don't have enough data to say that ivermectin should be included as part of treatment. It's always, interesting whenever one gets new ideas that a particular medication might work. But at this point in time, and we've just finished updated our guidelines at Sickle, and that does not include ivermectin.
Thank you very much. I will move to the next question. Is there a reason why we have never had a vaccine for the common cold? They are both coronavirus. What is the difference?
Yeah, that's a great question. The common cold virus, most of the there's several viruses that cause the common cold. The common viruses that cause the common cold, we use common twice there, are rhinoviruses that are different than the coronaviruses. But there are a family of coronaviruses that can cause common cold-like symptoms. To develop a vaccine, there are a number of things that need to drive its development. The most important thing is how important it is for there to be a vaccine to prevent that particular illness. And so one would argue, that trying to prevent a disease like hepatitis B or meningitis would be much more important than trying to prevent the common cold. That said, yes, work has and continues to be done to try to see if one could indeed come up with a vaccine that is directed at the common cold. It's just that developing vaccines against these viruses, there's several different viruses causing the common cold, would be challenging.
Thank you, Dr. Mburu and Dr. Harling. Next question. What are the side effects of the vaccines?
In the studies so far, the major side effects tend to be local and systemic. Local in the sense of a sore arm, systemic in the sense of muscle ache, fever. And those, in addition to that, very rarely one might have allergic reactions. But so far, the side effects are relatively mild and rare. As I mentioned earlier, the side effects in terms of the systemic symptoms of aches and headaches and fever tend to be more common after the second dose rather than the first dose. The way that I often look at this is on a scale of 1 to 10, where 1 is a bad vaccine in terms of side effects, and 10 is a great vaccine with little or no side effects. These vaccines would be closer to the 10. An example of a great vaccine, and I don't have any shares in the company of this that makes this vaccine, but a great vaccine that is associated with little or no side effect would be something like the pneumococcus vaccine that prevents pneumonias and meningitis in patients with sickle cell disease. It may cause a sore arm, but it's very, 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 very safe. The mRNA vaccines are close to that in terms of overall safety. Not identical, but they're close.
Thank you. Another question is the vaccines 100% guaranteed to protect against the virus? There is no chance that a vaccinated person can get COVID-19 again?
So yeah, that's a great question. The vaccines in the studies were shown to be about 95% efficacious. So 95%. So they're not 100% efficacious, but 95% is really great. The measles vaccine is like 98% efficacious. So we know, so that's pretty good. The 95% is pretty good. It is still early days yet as to whether or not you will get COVID after 2 doses of the vaccine and how long the immunity lasts. So the work that is being done as we speak to try to understand that as to how long the protection will last. The way that I think about it though, is that when we think of vaccines and what they're doing, we think of 2 outcomes. One, is the vaccine going to prevent any infection? In other words, you get COVID, or yes or no? Or is the vaccine maybe even if you get COVID, you're not going to get the severe COVID, but you get the mild COVID? It is likely that if you get vaccinated and your immunity wanes, my feeling is that it's likely that if you get COVID after that, it's probably going to be mild COVID.
Okay, thank you. I also want to add that, we do hear that today saying that the COVID-19 vaccine can only last in your body for 1 year. Is that true, Dr. Harlan?
So we don't know that for sure yet, and we're just going to have to wait the time to, for the studies to be done to be sure. But I think that the most important, in fact, this question relates to my earlier point, is that even if we need an additional booster, which I think we might need, I don't know, but if we do, the worst that would happen is that would probably be like the flu vaccine, where we may need boosters in the future, but we don't know that for sure just yet.
Thank you. Another question is, what is the recommendation for those who either already confirmed to have had COVID-19 or think that they may have already had COVID-19 with respect to getting the vaccine and parity for getting the vaccine? So what is the recommendation for those people?
The current recommendation is that if they have had COVID, the vaccine is still recommended and it is safe. What I would say though is that although we don't have the data, it might be prudent to wait until you have well recovered from the COVID before you get your vaccine. And that's one of the main reasons for that is that during the course of COVID, the closer you are to when you're symptomatic, the chances are your antibody levels will be higher. And those antibody levels, we don't know what effect that might have on the vaccine taken. So once you've recovered, you should wait. You know, my niece was a nurse in the States, had COVID and she's fully recovered. And at her hospital, they're waiting a couple of months to vaccinate her. I don't know that you need to wait that long, but probably maybe about a month or so, then you're fully recovered. You could be vaccinated.
Thank you.
Thank you.
We'll move to the next question. We are getting very good questions from the audience. Thank you, audience, for your participation. We have had cases of people getting reinfected. What is the chance that even after being vaccinated, you can still not get reinfected later with the virus?
Yeah, that's pretty similar to what we said before. We don't have those data yet. We really don't know how protective, how long the protection will last. But the good thing is that I think that if you were to get reinfected again, it's probably going to be a milder infection, because there's a good chance that your immune system will have some degree of memory protection.
Excellent, thank you. To the next question, what is going on in sub-Saharan Africa? There seems to be less COVID in those regions. Are there any genetic susceptibilities?
We are interested in the area of genetic susceptibility. As a matter of fact, we don't have the data to support that theory one way or the other as yet. There are some preliminary studies from the United States that indicate certain potential markers of increased susceptibility in some populations, including the African American population. But to generalize that more widely to the Black populations around the world, we just don't have the data yet. But it's an interesting question, and it's the subject of research at the moment, including some of what we're doing in one of our studies.
Excellent. How do you know when you are fully recovered from COVID-19?
It really depends in terms of when you're fully recovered. It really depends on the types of symptoms that you had to begin with. And so it really varies from person to person. But what I would say is that if you had fever that went away, then you know that once the fever is gone, you know that you are recovering. If you had fever associated with cough and the cough is still there, it doesn't necessarily mean that the infection is still there. The infection would have gone, but you may still have a residual cough. So it's hard to make a definitive statement with respect to when one would see themselves as being fully recovered in terms of a timeline. The bottom line, though, is that the vast majority of individuals have a mild illness, and when they recover, typically most people will tell you that by the end of the first week, you know, of having symptoms, I'm feeling better. By the second week, I'm feeling a lot better. And by the third week, I'm pretty more or less, you know, fully recovered. But we do know that some people have persistent symptoms that last for a longer time.
Thank you very much. We will continue with the questions. Are there any sickle cell patients in Canada that have been given the vaccine yet? And if so, what follow-up investigations have been done so far to see if there are any major side effects or not to this group of patients?
We don't have any follow-up data with respect to outcome among individuals with sickle cell disease. To my knowledge, the vaccine has not been given to individuals who we would call sickle cell patients. However, I am aware that some adults with sickle cell disease who are working in the healthcare system as healthcare workers have gotten the vaccine as healthcare workers because they're healthcare workers are supposed to be in sickle cell disease patients. So that we just don't have enough numbers of those to draw any conclusions as yet.
Okay, good.
Thank you, Dr. Allen. We will continue. There's a question from those who are watching us live on Facebook. One of the questions is, are sickle cell patients on priority list for the vaccine? I think you kind of answered the question a bit, but maybe you can expatiate where are sickle cell patients when it comes to priority for the vaccine?
Well, you know, the priority lists are still being worked out, but we do know that patients with sickle cell disease are among those who are at risk of having severe COVID disease. So they will be on the list of patients who should be prioritized once we get to that stage of the vaccination effort.
Thank you, Dr. Allen. Next question. I think you might have also answered this, but maybe you can reiterate again. What results of tests of the vaccines? So I believe what the individual is asking is, what are the results of the vaccines test for people with sickle cell and asthma and allergies? So I think they're wondering, people that have sickle cell or asthma or allergies, what has been the outcome for them when they've gotten the vaccine?
We don't have enough data from the post vaccination surveillance yet to draw any conclusions. And those sort of data were not crystallized out of the clinical studies because of numbers. You don't have enough numbers of individuals at that specific set of of variables to analyze.
Thank you.
The next question is similar as well. I'm not sure if anything was said regarding allergies and the Pfizer vaccine, but is it true people with allergies shouldn't take the vaccine? And I will just ask the next one, which is also very similar. How should people with anaphylaxis approach the vaccine, and are they at high risk of suffering an adverse reaction?
So the only real contraindication to any vaccine, well, these vaccines, would be if one is allergic to one of the components of the vaccine. So if you're at risk of anaphylaxis to peanuts, there's no reason why you would have anaphylaxis if you got vaccinated, because it's specific to that particular allergy. So so people who have had severe allergic reactions can still be vaccinated. They just need to tell the people vaccinating them so that they can be observed for a longer period of time. So I think that's the main point there. Now, your question though brings up another question, and that is, so what exactly are in these vaccine vials? For the mRNA vaccines, it's actually surprisingly and pleasantly incredibly simple. The Pfizer vaccine has 5 different types of lipids that I alluded to. It's like the coating, chocolate coating of that raisin that I referred to. There are 5 of them in one of the vaccines, and the other has 4. The vaccines have sodium chloride, salt, potassium salt, sodium phosphate, potassium phosphate, sucrose, sugar, and really not much else, you know. So it's so sugar, salt, water, lipid. It's really meant to stabilize the product and also allow for the pH to be at the right balance as well, and so that the injection site is not too painful and the product doesn't break down. So they're really quite simple in terms of what's in there. It's not a lot, but there are a couple of things in there that people might react to, and one of them is called PEG. So that's where there's a lot of attention being directed at whether or not there are any components of the vaccine that people have reacted to previously. Then the vaccine would have to be regarded as relatively contraindicated for those individuals. But if you've had anaphylaxis to penicillin, that doesn't mean that you can't get vaccinated.
Thank you. Thank you so much, Dr. Harlin. From folks who are joining us from the WhatsApp, a question is, with the known fast mutation of the cold viruses, what gives us the assurance that another vaccine may not be needed to replace this in a few months?
Yeah, this relates to what's been in the news about the variants that have emerged, the COVID variants, such as the UK variant. It is quite possible that in the future we might need to modify the RNA, the mRNA template to create a slightly modified vaccine. The bottom line is that if that is needed, it can be done literally overnight, really in a very short period of time. So we can't say for sure that we won't need to modify the vaccines. Hopefully we don't, but if that's the case, that could be done pretty quickly. And so if you look at the influenza vaccine, the flu vaccine, changes are made every year. Hopefully we won't have to do that for COVID-19, SARS-CoV-2, but hopefully if we have to do that, it can be done pretty quickly.
Okay, thank you. Next question is, have there been any deaths as a result of taking this vaccine?
Generally, vaccines are really safe. There were reports of mortality, as I recall. I have to double check to see what which one of the vaccines it was. But the bottom line is that when you look at the chances of having a bad outcome, such as mortality from the vaccine, compared with the mortality from COVID, it's really, they're not comparable. The deaths that occurred in this Pfizer study, as I recall this now, were not felt to be related to the vaccine, at least in this study. Were not felt to be related to the vaccine.
Mm-hmm. The next question is, how long in years has work been going on in this mRNA vaccine? Has there been an opportunity to try it on mammals other than man?
The with the need to get a vaccine out, you know, it's important to ensure that the vaccine works in humans, and because it was really felt that the vaccines needed to be studied in humans and they were felt to be reasonably safe. The studies involved humans pretty earlier on, and we're very fortunate that so far the data show that they're really quite safe in humans. So trying to study them in animals, that type of work for 2020 was not as needed as would have been 20 years ago. As I said, you know, work's been done on mRNA vaccines for decades now.
Okay, thank you. What happens if one does not get a second dose of the vaccine in the specified time?
We don't have as much data. There's a feeling that we could probably wait until about 6 weeks. I think Health Canada feels that that's the case for the second dose. Waiting longer than that, we really don't know. In using these vaccines, we really try to focus on what was looked at in the clinical trials. And in the clinical trials, the Pfizer vaccine, 2 doses, 3 weeks apart. The Mrna vaccine, 2 doses, 4 weeks apart. Longer than that, you know, probably out to 6 weeks. Much longer than that, we just don't have the data.
Thank you very much.
Thank you, Dr. Mburu and Dr. Harlan. Quickly, we will take a few more questions and chat, and then we'll go to those who raise hands, and then we go back to Q&A. Next question. How do we determine how often we need a vaccine? Is it a matter of observing the population, or are there clinical studies that would determine that? How often we should be vaccinated for the COVID-19?
That will come from studies that look at how long the immunity will last. And as soon as we have that type of information, we'll be able to determine if we need additional doses, i.e. how often the vaccine will be needed in the future. Hopefully, hopefully not like influenza, but we just don't have the data as yet.
Thank you. Can a person be reinfected after being cured from COVID-19?
There have been reports of reinfection after people have had COVID, and that unfortunately, there have been at least one bad outcome as a result. But when you think about the fact that there have been over 93 million people around the world who've been infected with COVID, we only hear about a few reinfections, it means that reinfections are incredibly rare. Now, what we don't know is, well, what will happen a year after you've had COVID. The reinfections we're talking about are within the first 3 to 6 months or so, and that seems to be rare.
Thank you very much. Quickly, this individual is giving a comment that there are 3 guys infected with COVID-19 in his office. The hospital around instructed them to take vitamin C and dexamethasone, lemon and ginger, and then isolate themselves. 3 weeks later, they tested negative. What happened?
We have no evidence that vitamin C and ginger and lemon would have any effect on clearing the virus. We should also note that if you were to just do nothing, 3 weeks later, most people would have to clear the virus as well. So we don't have any data to suggest that. Doesn't mean that one shouldn't take those if that's what they do to stay well. But as a COVID-specific treatment, there's no evidence to recommend their use.
Thank you very much. Can people with fibromyalgia take the vaccine?
Yes, fibromyalgia and rheumatologic disorders are not felt to be a contraindication to taking the vaccine.
Thank you.
Over to the next question. What are the ingredients of the vaccine? I believe you already alluded to this. The individual points out, are we supposed to take a vaccine without knowing what's been placed in our bodies? What research has been done on the safety of the vaccine regarding sickle cell patients when no previous research has been done specifically on sickle cell patients?
Well, in terms of the ingredients, you know, I had the same questions when the vaccines came out, and I don't work in a vaccine lab, so I had to go to the internet to find out what's in the vaccine and read the medical journals to see what's listed. And it's pretty, it's pretty, you know, straightforward. You know, there are lipids, some salts, and sugar. Those are essentially what's in, and of course the mRNA. There isn't a lot in this vaccine.
Okay, thank you very much. From the Facebook group, are these vaccines supposed to be area specific as we see on social media? The COVID vaccine is labeled not for use in Canada, Europe, and the USA.
So that's an interesting point. The way that medications are approved, the approval is jurisdictional, okay? So that a company, for example, can't label a product, sell it in Canada and label it for use in Brazil without the Brazilians agreeing to that. As soon as, you know, everyone agrees to that, then you can modify the label accordingly. But if approval is granted for the United States, it has to state that it's the United States. And that's what that's all about.
Thank you, Dr. Harlan. We have Juliano raised her hand. Juliano, can you ask your question at this time? Thank you. Juliano, can you unmute yourself to ask your question?
Hi, Dr. Allen.
Nope.
I want to thank you for a highly educated session on the coronavirus and the vaccine. Unfortunately, most of my questions have been answered already. My question was related towards allergies, as I have the shellfish allergies, and wanting to know what were the properties in the vaccine and what precautions should I be taking?
So that's a great question. I know someone who has a shellfish allergy and who had a vaccine recently. It's okay. I mean, you should tell them that that you're allergic to shellfish, rather than, you know, when I got the vaccine, they observed me for 15 minutes. You would probably get observed for half an hour. But it is safe if you have a shellfish allergy.
Okay. Thanks very much.
Great question.
Petrina, can you ask your question? Thank you.
Okay, my question is about, I have sickle cell and I also have asthma and allergies to food and some medication. So that's like my main question when I ask if somebody has all three.
Yeah, you know, even if you have multiple allergies, the vaccine is still regarded as safe as long as you're not allergic to something that's in the vaccine. And And if you're not allergic to something that's in the vaccine itself, in the vaccine vial, then what they would do is just observe it for a longer period of time, half an hour usually, to make sure that everything is okay.
Thank you. We're going to move back to the Q&A. What are the clinical outcomes for patients with COVID and sickle cell? Worse or much worse, or how does that compare?
People with sickle cell disease were among those who are seen to have a greater chance of having severe outcomes. Earlier on, some people ended up in the intensive care unit, for example. So severe COVID is more likely in people with sickle cell disease. And so I think that is an important point to bear in mind. And so once the rollout of the vaccine starts, sickle cell disease patients will need to be prioritized for vaccination.
Thank you very much. If you are vaccinated, can you still be a carrier of the virus?
So that's a great question. We don't have enough data as yet, but there's that possibility that indeed you might still be able to carry the virus for a period of time and transmit. It's not a virus that you carry for a long time if you have a normal immune system. We're talking about being infected and then having the virus hang around in your respiratory tract for a couple of weeks. That might be possible despite being vaccinated. We just don't have enough data on that for sure as yet, though.
Thank you very much. What is the impact of the UK strain in terms of severity of outcomes in the general population? What about children? I guess in regards to the UK strain.
As far as the UK strain, we're still getting data on that as to it looks like it might be more transmissible. There's some question as to whether or not severity might be an issue as well. The verdict is still not completely in on that. There's some signals that it might be more likely that children will transmit it, but it's still a subject of data gathering and research.
Okay, thank you very much. And I believe we're approaching our final questions. What do we say to our anti-vaxxer community?
Well, you know, I always say that I never really, I don't really regard people as anti-vaxxers. I think of people as in two categories. Category number one is being in that information seeking phase where, you know, if you've been confronted with a vaccine for the first time, you know, you want to know about it. I wanted to know what's in these vaccines in June, July. I wanted to know. So we're all in that, many people are in that information gathering, information seeking phase. The second phase is that now once you get the right information, you know, you have a right to decide if you want to be vaccinated. If when you get the right information, you decide that you don't want to be vaccinated, you're hesitant, it's your right. But at least what I, as an infectious disease expert, would want to be sure is that if you decide that you don't want to be vaccinated, I don't want you to make that decision because you thought there was a microchip in the vaccine when that's not possible, there's none. I don't want you to make that decision because it's going to change, you think it's going to change your genome. I want you to make the right decision, but not decisions based on wrong information.
Okay.
So that's a really important point.
Okay. Thank you very much. I'll move to the next question. What do we say to our pregnant and breastfeeding women? Can they get the vaccine?
Yeah, that's a great question. And I'm, a member of the one of the advisory groups looking at that. The feeling that we have and others is that it is safe for pregnant women to be vaccinated. We encourage people to have a conversation with their obstetricians. And there's question is, if you're going to be vaccinated, do you want to wait until after the first trimester? Probably wait, but there's some discussion around that. And I think it's important though to recognize that it is felt to be safe, but have a conversation with your obstetrician. And similarly for breastfeeding, it is regarded as being safe for moms who are breastfeeding.
Thank you.
Thank you, Dr. Allen. A Facebook question. If found a life-altering side effect was caused by the vaccine, is anyone liable?
So that's a great question. If one takes a medication such as penicillin for your sore throat and you get a life-altering side effect, who is liable? The important thing is that when we take medications or vaccines, we do so with informed consent. We have a right to say yes or a right to say no. And so I think that's really important for us to bear that in mind. If and I'm not a lawyer, but if there was a major side effect related to a medication or vaccine or anything that was not disclosed, the side effect was related to an ingredient that was somehow, for whatever reason, somebody found that, it happened and they, nobody, companies didn't tell people about it. That's a different situation. But in terms of disclosing all the information that we know about the vaccine and all the risks versus benefits that are known, it amounts to a personal responsibility on our part.
Thank you, Dr. Harlan. Two questions. Same question from two different people. It's around allergic reaction to flu shots. So if they've had negative experience or they're allergic to flu shots, should they be taking the COVID-19 vaccines?
It should be discussed with your doctor, but there's no reason to think that they cross-react.
Thank you. And I think you've shown this to us in one of your slides, but there's a question again from someone. They're asking, how does mRNA act on the brain?
We have no evidence. It's a great question. We have no evidence that the mRNA is causing the expression of proteins in the brain to cause any problems with the brain. The important thing is that even if there were to be any effects on organs such as the brain or heart or liver or whatever, if those are occurring, they've got to be incredibly rare, like incredibly rare. Given where we are today, so far, millions of people have gotten the vaccine so far. We're not where we want to be in terms of the number of folks who have been vaccinated, but millions of people have been vaccinated so far, and we're not seeing these effects emerge. So if they were to happen, they got to be incredibly rare.
Thank you. One more question. Which brand of the vaccines is safe for a child with type SC? So with sickle cell SC.
I don't believe that the type of sickle cell, SS or SC or trait would influence the safety of any of these vaccines. I think that there would be, I really expect that they would be comparable. I think that the issue of safety is more going to be an issue of other factors as opposed to sickle cell disease.
Thank you, Dr. Allen. We will allow one individual who have raised hand to ask a direct question. So Shiyan, can you speak? Shiyan.
Hi, thank you so much for the amazing session. Dr. Allen, thank you so much for your time.
Welcome.
I'm actually bunking in from Europe, and I haven't had anything like this. So thank you for the information. My question is this. I think it buttresses on what Eunice asked initially. I was hoping we're going to have like a presentation like you did for the vaccine, which kind of showed what it will with sickle cell. I'm in my 50s and I have sickle cell disease. I also tend to have acute chest syndrome. So particularly for me, the vaccine, I am scared, like Eunice has mentioned. If it's introduced to my body, do I need to prepare my lungs in readiness in case something happens? So basically, that's my fear, that's my concern. By the time I'm asked to come for it, is it going to cause my lungs to need, do I need to have transfusion ahead of time to make sure my hemoglobin is high enough so that if anything happens, I am not, left vulnerable more than I am already? And that's my question. I hope it was compact enough.
Yeah, Sayan, I think it's a great question. The way that I would say this is that I really don't think you need to do anything differently than you're doing to keep yourself well. Okay. That said, if you were going to undergo a minor procedure, you want to do it when you're well. You don't want to do it when you're having a fever or you're just recovering from another illness. You want to do it when you're in top shape. But in terms of something specific connected with any of these vaccines and acute chest syndrome in the context of sickle cell disease, we don't know of any such connection.
Okay.
So I would say for you that, be well when you get it, and the benefits of the vaccine come far, and I really, saying that this is with uppercase and underline, far exceeds risk in particularly in your case.
Okay, thank you so much. And thanks everybody, it's been amazing. Thank you.
Welcome.
Thank you.
Thank you. I'm approaching the last two questions. Thank you, Dr. Alvin, for your time. If you have parents in their 70s with high blood pressure, is it safe to take the vaccine?
Yeah, that's a great question. I would say yes, it is quite safe. It is quite safe. But I'll also add a little spin to that. It's almost like what I said to Cyan earlier on, in that if you have high blood pressure and you're going to undergo a procedure or something, a minor procedure, what have you, you want to go when your blood pressure is controlled, right? You don't want for there to be your blood pressure being uncontrolled and shooting up because of the added anxiety associated with just being in a medical setting. So control your underlying medical condition. But as far as before you get vaccinated, but as far as a specific contraindication, it's not contraindicated.
Okay, excellent. The next question is, is there an issue if the first vaccine is from Pfizer and the second vaccine is from Moderna? Is there an issue with mixing the brands of the vaccines?
Yeah, that's a great question. I asked myself the same question a couple of months ago. I wouldn't mix them because they weren't studied that way. So I wouldn't mix them. I don't, the doses are different. They're formulated and packaged in a vial a bit different. So I wouldn't mix them, and that's not recommended.
Okay, and to our final question, what procedures are in place when traveling on a plane currently in Canada if you have to fly for essential reasons?
They really do change. So I'm gonna defer a definitive answer on that and say what I would probably do is what I have told some of my patients who have asked me a similar question, is just check with the airline before you book. There are some airlines that, depending on where you're flying now, that will require evidence of you being tested and being negative for COVID. Some are also testing you at the airport. So I think that and then of course the screening that happens at the airport, temperature checks before you board a plane, some depending on the airlines, and also questions about who you've been in contact with and your symptoms. So I think it's really important to, before you travel, to be checking what are some of the requirements and what are things that will be in place on the plane before you go.
Great.
You should also check as well if you're going to a particular state, province, or country. Just be mindful of what the conditions will be when you land. I've heard of people being upset when they landed in some countries and they were told that they had to quarantine and stay in a resort, with a tracking device for 2 weeks. So you need to be aware of that before you venture on your trip.
Great, thank you very much, Dr. Allen. Ms. Landry will be giving their final closing remarks. I really thank you for taking your time to educate us on a Saturday about this very important issue at this time. I think what I'm hearing you say, there's a lot of work that's still being done and we are going to learn about, and hence we should not let down our guard from the public health measures of social distancing, wearing a mask, sanitizing to try and keep each other safety as we all try to get the vaccine. Thank you.
Absolutely, I agree with you 100%.
Thank you so much again, Dr. Allen. We couldn't thank you enough. And thank you, Dr. Humburo, for being such an excellent co-moderator. I enjoy working with you. To the folks, I want to thank you so much for joining us today. I want to also acknowledge that we have Ms. Jenny Gomes on the line today, who is the chair of the board of directors of the Sickle Cell Disease Association of Canada. We have great people, Shinya and Laura and all the great folks from UK joining us today. Thank you everyone for being on this call. Our most gratitude goes to Dr. Upton Allen again for giving us his Saturday. Now I know we have a lot of questions more, but again, it's almost 1 o'clock. And so I want to ask if you have any further questions. I've put the email address in the chat box, which is communication@sicklecellanemia.ca. You can forward your questions to that email address and we will make sure Dr. Upton Allen gets the question and answer your questions. But I think for myself, I've been very much educated. Most of my own fears have been allayed. Thank you so much for doing such a great job. And we want to wish every one of you a very enjoyable weekend. We ask you to keep on staying safe and well. Now, before Dr. Allen goes, quickly in 1 minute, Dr. Allen, I know there is an upcoming COVID-19 immunity clinic that we will be holding in the community here in Toronto. Can you quickly in 2 minutes talk about it and why, even though you get vaccinated or not vaccinated, that is still good to be part of that clinic in 2 minutes?
Oh, yes, thank you. Yes. So one of the things that we're doing, one of our research projects tries to get a better extent of the extent to which COVID has penetrated into the Black community. And then also why, in other words, who are the individuals who are most affected, so that we can provide information that will inform policy at a governmental level and bring about change. Plus also the studies that we'll do will hopefully benefit individuals. And so we'll be able to do a test. It's a simple test to determine if the person has antibodies to the COVID virus. Even if you're vaccinated, we can still check for antibodies. And if they're positive, we can actually offer to follow you to see if the antibodies disappear or stay over time. And someone had asked about that earlier. And so that would be one way that we can track changes over time. So we'll have some more announcements about that, and we'll share that with Ms. Laundrie so that we could have you involved in that particular project.
Thank you, Dr. Allen. So folks, as you heard, that clinic is coming up shortly. If you want to know your immunity to COVID-19, I definitely want to know. You should be a part of that clinic. Thank you again, everyone. Enjoy your weekend, and we'll talk to you shortly. Thank you.
Thank you. Have a good weekend. Bye-bye.
Thank you, everyone.
Bye-bye.